Patellofemoral pain syndrome (PFPS) is one of the most common causes of anterior knee pain, affecting individuals of all ages and activity levels. Often referred to as runner's knee, PFPS is characterized by pain originating from the patellofemoral joint, where the patellar kneecap articulates with the femur thigh bone. The condition is particularly prevalent in athletes, runners, and individuals who engage in repetitive knee-loading activities such as squatting, jumping, and climbing stairs. However, it can also affect sedentary individuals, particularly those with muscular imbalances or poor movement mechanics. Despite its common occurrence, the exact causes and mechanisms underlying PFPS remain complex, with multiple contributing factors including biomechanical abnormalities, muscular imbalances, overuse, and improper movement patterns. The patellofemoral joint plays a critical role in knee function, allowing smooth movement of the patella along the femoral groove during activities such as walking, running, and bending the knee. The patella serves as a fulcrum, enhancing the mechanical advantage of the quadriceps muscle and distributing forces across the knee joint. In a healthy knee, the patella glides smoothly within the trochlear groove of the femur, guided by surrounding soft tissue structures, including the quadriceps, patellar tendon, and medial and lateral retinacula. When this tracking mechanism is disrupted due to factors such as muscular weakness, tightness, or malalignment, excessive stress is placed on the patellofemoral joint, leading to pain and dysfunction. The primary symptom of PFPS is diffuse anterior knee pain, often described as aching or dull in nature. The pain is typically aggravated by activities that increase patellofemoral joint loading, such as stair climbing, squatting, prolonged sitting, or running, particularly on uneven surfaces or downhill. Some individuals also report sensations of instability, grinding, or clicking in the knee. Although true mechanical locking is uncommon in PFPS and may indicate another underlying pathology, such as a meniscal tear, swelling is generally mild or absent, and the pain is usually not associated with acute trauma. The exact cause of PFPS is multifactorial, involving a combination of intrinsic and extrinsic factors. Intrinsic factors include anatomical and biomechanical abnormalities that predispose the individual to improper patellar tracking. These may include excessive femoral anteversion, inward rotation of the thigh bone, genu valgum, knock-knee alignment, patellar maltracking, and altered foot mechanics, such as excessive pronation. Muscular imbalances, particularly weakness of the quadriceps, especially the vastus medialis, oblique, and tightness of the iliotibial band, hamstrings, and hip flexors contribute to abnormal patellar movement and increased stress on the joint. Extrinsic factors include training errors, improper footwear, and sudden increases in activity levels. Athletes who rapidly increase training intensity, frequency, or duration without adequate conditioning are at higher risk for developing PFPS. Running on hard surfaces, wearing unsupportive shoes, and performing repetitive high-impact activities can further contribute to patellofemoral joint stress. Poor movement mechanics, such as excessive knee valgus inward collapse of the knee during squatting or running, are also common contributors to PFPS, particularly in female athletes, who are at higher risk due to differences in hip anatomy and neuromuscular control. Diagnosis of PFPS is primarily clinical, based on patient history, symptoms, and physical examination findings. There are no specific imaging studies required for diagnosis, although X-rays, MRI, or CT scans may be used to rule out other causes of knee pain, such as osteoarthritis, patellar fractures, or cartilage lesions. The physical examination typically reveals tenderness along the patellar margins, pain with patellar compression, such as during Clark's test, and weakness or delayed activation of the vastus medialis oblique. Functional tests, such as single-leg squats or step-down tests, may reveal dynamic knee valgus or poor hip stability, indicating underlying biomechanical contributors to PFPS. Treatment for PFPS is primarily non-surgical and focuses on reducing pain, correcting biomechanical abnormalities, and strengthening the muscles that support the knee joint. The cornerstone of treatment is physical therapy, which includes a combination of strengthening, flexibility, and neuromuscular training exercises. Strengthening exercises target the quadriceps, particularly the vastus medialis oblique, which plays a crucial role in stabilizing the patella. Closed-chain exercises, such as squats and leg presses, performed within a pain-free range, are generally preferred over open-chain exercises to minimize patellofemoral joint stress. Hip strengthening exercises are equally important, as weak hip, abductors, and external rotators contribute to excessive knee valgus and increased patellar stress. Flexibility training focuses on addressing muscle tightness, particularly in the quadriceps, hamstrings, iliotibial band, and hip flexors. Foam rolling and stretching exercises can help reduce excessive tension and improve patellar mobility. Neuromuscular retraining involves correcting faulty movement patterns and improving proprioception, balance, and coordination. This may include gait training, single leg, stability exercises, and plyometric drills to ensure proper knee alignment during dynamic activities. In addition to physical therapy, activity modification is essential in managing PFPS. Patients are advised to reduce or temporarily avoid activities that exacerbate symptoms, such as prolonged running, deep squatting, or stair climbing. Low-impact activities, such as swimming or cycling, can help maintain cardiovascular fitness while minimizing joint stress. Gradual return to activity, with emphasis on proper warm-up, cool-down, and progressive loading, helps prevent recurrence of symptoms. Footwear and orthotic interventions may be beneficial, particularly for individuals with excessive foot pronation or poor arch support. Shoe inserts or custom orthotics can help improve lower extremity alignment and reduce patellofemoral joint stress. Typing techniques, such as mecanal typing or the use of patellar stabilization braces, may provide short-term pain relief by improving patellar tracking and reducing excessive lateral movement. Medications such as nonsteroidal anti-inflammatory drugs and NSAIDs may be used to manage pain and inflammation, although they should not replace physical therapy as the primary treatment approach. In cases of persistent pain that does not respond to conservative measures, corticosteroid injections or viscosupplementation with hyaluronic acid may be considered. Although their long-term efficacy in PFPS is not well established, surgical intervention is rarely necessary for PFPS and is reserved for cases that fail to improve with prolonged conservative management. Surgical options may include arthroscopic procedures to remove damaged cartilage, lateral release to reduce excessive lateral patellar pull, or tibial tubercle osteotomy in cases of severe patellar malalignment. However, These procedures are not commonly performed and are generally considered only after exhausting all non-surgical treatment options. Prevention of PFPS involves addressing modifiable risk factors and maintaining optimal knee mechanics.
Strength training programs that target the quadriceps,
Hamstrings, and hip muscles can improve joint stability and reduce stress on the patellofemoral joint. Proper warm-up and stretching routines before physical activity help maintain muscle flexibility and prevent excessive strain. Athletes should focus on proper running techniques, avoid excessive knee valgus during squatting and jumping, and use appropriate footwear to support foot and lower limb alignment. Patellofemoral pain syndrome is a common and often debilitating condition that can significantly impact daily activities and athletic performance. Although the exact cause of PFPS varies among individuals, a combination of biomechanical, muscular, and training-related factors contributes to its development. Early diagnosis and intervention are crucial in preventing chronic symptoms and long-term complications. Most individuals with PFPS can achieve full recovery with conservative management, including physical therapy, activity modification, and proper biomechanics training. Continued research in the fields of sports medicine and rehabilitation aims to further improve treatment strategies, optimize recovery outcomes, and prevent future occurrences of patellofemoral pain syndrome.